Everybody. My name's Bernadette Watson. I'm the director of the International Research Centre for the Advancement of Health Communication. And I'm very pleased today to introduce this joint talk, which is our Department of English and Communication and my centre, a talk on cancer patients' perspectives of their nurse-patient communication in a busy hospital ward. And I was just saying before we opened it up to people coming in, I think this is a very lovely way for me to spend an hour on a Tuesday afternoon. The topic that Associate Professor Angela Chan is going to speak about is very close to my heart. But I also know that it will be very interesting, and her experience will really assist with trying to understand this area a little more. Let me tell you a little bit about our speaker, Dr. Angela Chan. She's the Associate Director of the Centre of International Research for the Advancement of Health Communication, as well as an Associate Professor at PolyU and Associate Head of Pre-Service Education in the School of Nursing.
Bernadette, maybe I'll just interject for a sec.
Yeah.
I just wanted to share the good news as well. I just recently promoted to be the professor.
Yippee! That's marvelous. So Professor Angela Chan will be giving her, this is probably her first talk as professor, and that's really great.
Congratulations.
Yeah, that's absolutely marvelous. I had heard rumors, but I didn't know anything was known. So that's excellent. So Professor Chan will be talking about her research interests and some of the history around that. She's focused on caring, patient self-centered care, sorry, I'm so excited about the professor bit, and also interprofessional communication. She's also focused on handover and speaking up in the medical context, and all these are topics that are really close to my heart. But the interesting thing is that Professor Chan will take a slightly different perspective than do I, and I think this is going to be a very informative and interesting and thought-provoking talk. So I think Professor Chan will talk for about 40-45 minutes, and then there'll be a chance for people to ask their questions. And I think it might be easier if people just wait and put their comments up in the chat box at the end, because it's hard for people to give a talk and see the chat box and respond. So I think it's much easier. So I'd like to hand over to Professor Chan, who, as I say, will be talking about cancer patients' perspectives of their nurse-patient communication in a busy hospital ward. Over to you, Angela.
Well, thank you very much, Bernadette, and good late afternoon, everyone. And this is actually really exciting for me. But before I start to share with you my study on cancer patients' perspective of the nurse-patient communication in a busy hospital ward, perhaps a little bit about my journey to healthcare communication, as Bernadette has alluded to a little earlier. My area of interest in research, education, and practice, with some examples here. I actually, as a nurse and a nurse educator, I've always been troubled by the common parlance about nurses don't have the time to talk to patients. So I look at the concept of caring within the context of time in nurses' busy clinical environment. Nurses tend to focus on the quantity rather than the quality of time. And I've learned from nurses who could do caring were able to use small talks during procedural care, and were often more observant, and they implement care at the right time. For example, offer a needed glass of water in a very timely manner. And the process of communication that I've learned is in the moment of encounter between the nurse and the patient, and it is often open-ended. That is, what is being said will be the beginning of the next sequence of communication. And often the nurse-patient communication is not necessarily about problem solving, but simply for nurses to listen. And so I always told students that you don't necessarily have to worry about need to solve the problem right on that spot, because it's open-ended. And then the other thing that I also pay attention to is communication between nurses during shift handovers is another important issue, in particular for newly graduate nurses and junior nurses. In our studies, what we found is the lack of a structure with minimal interactions between the incoming and outgoing nurses, which has often led to assumptions of what's being understood by the incoming nurses. Then my doctoral students work in looking at the narrative experience of newly graduate nurses, which also reveal the issue of speaking up within a certain culture, and again links to a particular pattern of communication between senior and junior health professionals discussing patient conditions. But ultimately, my journey brings me back to examining the person-centered care in theory and in practice, and that's very dear to my heart. Sadly, oftentimes it remains less than ideal, even when the advanced practice nurse manage their care for cancer patients in nurse lab clinic. So what I've been doing recently is to look at the palliative care communication. Now, this is an important aspect simply because we have ever increasing aging population with chronic illnesses, and how palliative care is no longer cancer specific. And also there's a trend to initiate palliative care much earlier with patients and their families so that they can be active partners in the process, especially with advanced care planning. And my latest work also focuses on the palliative care communication, is particularly in education, to prepare our newly graduates for the future nurses. But today I would like to share with you an example from part of a larger study which addressed a contextualized understanding of nurse-patient communication and its impact on nurses' learning and patient satisfaction. So this is not
just interrupt. I'm awfully sorry, Angela, but people are saying that there seems to be a problem with the sound. I'm not sure why. They're saying there's some kind of background noise. It's okay for some people, but
okay,
not
maybe
others.
if I turn off the air conditioning, see whether that will be better.
Oh, maybe, yeah, maybe.
Okay, I just turned it off.
Okay.
So
righty-ho. Carry on, and people just let me know in the chat box. I'll keep an eye on it.
Okay. So basically, I'm focusing on a part of larger study, which is the contextualized understanding of nurse-patient communication and its impact on nurses' learning as well as patient satisfaction. And for all the study that I've done, the methodology, I usually adopt mixed methods, ethnographic approach, and a descriptive and interpretive qualitative study. And sometimes I might be using the conversational analysis with or discourse analysis with colleagues as well. So, but today I'd like to talk about cancer patients' perspective in particular, simply because patients' perspective is the most important. They are the recipient of care. And in the literature, it is very clear that if it is not perceived by the patient as caring or as effective, the care that's rendered remains fruitless or remains futile. So it is very important that we look at it from the patient's perspective. And also it's noteworthy from the literature that's also appears to be disparity between the nurses and the patient's perception in terms of the amount of communication and the amount of caring being involved or rendered. So just to look at the importance of communication in cancer care, I think grossly we can say that's basically two groups. We have patient that is presumably treated, cured, but then obviously many of them are in remission. And then the patient that will have deteriorated conditions and require palliative care. And so with this two group of patients, they have different needs of emotional conversation that will maybe meet their psychosocial needs. Just because somebody's in remission doesn't mean that they have no worries, because every time when they go back, they worry about whether the cancer cells have come back or not, So there's a lack of discussion over psychosocial issues often found between nurses and patients. Inadequate psychosocial care comes from insufficient quality of communication, and ultimately this all kind of led to communication that's being met. And so if we're going to bring it back to Hong Kong, a little closer to home here, we know that ineffective communication is often found in healthcare. For those of you out there that's linguists that may be doing some healthcare communication locally, I'm sure that you agree with me. Healthcare, communication in healthcare is very important. And the fact that when we talk about ineffective communications in healthcare, we are looking at not just the, how would I say it, um, let's see, um, we're looking at not just the nurse-to-nurse communication, but also within the healthcare, healthcare professionals. And even when we're looking at the seminar report from Hospital Authority, we have like the communication is definitely an issue, which lead to patient safety, or in my case, it lead to maybe some kind of distress if it's not being dealt with in terms of the psychosocial issues. And so in Hong Kong, when we're looking at in an oncology setting, nurse-patient communication is even more important, but it's also very challenging. And the reason being is, again, with aging population, we have increased number of chronic illness and more cancer cases, and cancer cases now considered to be chronic illness as well. And for those of you that may not know, out of the 42 hospital from like under hospital authority, there's only 6 of them that have the oncology services. So, so that's not too many of them provide the services. And then we also are dealing with the generic issues of manpower shortage and time constraint. So if we looked at the communication, not about the healthcare team, but also primarily looking at the patient and health professionals, we could consider the stakeholders involved will be the patient and the health professionals. And the attributes that we can look at the patient's attributes. Sometimes it relates to the negative emotions because of the pain that they're suffering or they are experiencing. There's lack of specific knowledge about disease, inadequate communication skills, forgetfulness. And this is often, when we talk to the patient, this is very interesting that oftentimes they wanted to ask the health professional some things, but by the time that when the nurses or doctors arrive, they forget, simply because oftentimes they find the presence of the health professional is very short, very brief, and then they also came in with their own agenda, so patient tends to forget, and we usually advise them to probably, write down, what they wanted to talk about on paper with the health professionals. Perceiving points of problems, depends on how patients see their problems, whether they need to talk to their health professionals or not. Authority of the healthcare professionals, so it could be seeing them as authority. So they expect the health professional to instruct them of what to do, rather than they will be asking too many questions. Perceived nurse's attitude, if you're looking at the nurse-patient communication, so primarily it will be how the patient perceives the nurse's attitude, or maybe the patient has negative experience from before. Healthcare professionals, equally, they have their own attributes that contributes to this communication issues. How familiar are the health professionals with the patients? Whether there's any rapport building, relationship building with the patients, or maybe the health professionals, they have their own stress or own issues dealing with maybe the environment. And that certainly links to the external environment, which both the patient and the health professionals situate themselves within. It could be within understaffing, workload issues, time pressure. So those also influence how the nurse or the patient communicate with each other, or just health professional with patients. So the purpose of my talk today, again, as I said, to explore the patient's perception of the experiences with the nurses in terms of their communication, as well as the psychosocial care that they think that delivered by the nurses, and what's the expectation of it within a very busy environment. So what might be some of the influencing element or factors that may affect the patient's communication, and when do patients actually reach out or communicate with nurses about their needs, of the communications. So the general method for this overall study is a focus ethnography, and that was carried out definitely before COVID. If not, we will never be able to do that. And it's focused ethnography because we're looking at continuous problem of a nurse-patient communication, and it's a distinct subculture of cancer care within the context of our medical model. And the setting that we have is a local hospital with the oncology unit. We look at 2 wards there. And when we started off, we spoke to the ward in charge, and then after we got the ethical approval from the hospital as well from the university, we started to carry out this research. And the whole research team goes, like, basically we went to the unit to look at the setting, and then we spent about a week to understand how the setup and how the activities like. And essentially, there were 2 nurse researchers collecting data primarily after a week visit, over there. And then for this 2 particular nurse researchers, they spent 4 weeks just to observe. So in doing a general observation, like the field observation of the nurses' practice, their activities, and the general nurse-patient communication. And so, and we were able to talk to the nurse in charge, and for them to identify the suitable patient for us to interview or be involved. So by suitable patient, I mean the patient will be in reasonable health, that they will be able to carry out an interview, even though when they're tired, then we make sure that we don't do that. We stop the interview at any point in time, and at the same time, they might also be cognitive, like the cognitive functioning. That's no problem. And so when we identified the patient from the nurse in charge, we went to the patient and talked to them about the purpose of the study, see whether they're willing to join, and also seek their consent. And when the patients consented to do that, we go to their attending nurse to see whether the nurse was willing to participate as well. And so we're very fortunate, to have a pretty good sample size. And so the data collection, we look at field observations, and we also audio tape the routine procedure, and so that we can listen to the dialogue between the nurse and the patient during the admission, during the administration of medication, during wound dressing and discharge procedure. And these are basically the most common nursing routines procedure that happens during the day, like as the part of the main bulk of the work. And so then we thought this will be a place that we could start. And we also review documents. So the strategy, like I explained earlier, we have team participant observation as a whole team for a week, and then the 2 nurse researchers will continue with this general observation for a month, and they start to work with the nurse and the patient, audio tape the communication during procedural care, and then we'll have semi-structured interview with patient participant and also document review. And so with the data analysis, we triangulate the data, field notes, interviews, and also document review, thematic analysis. And instead of doing conversational or discourse analysis, we just simply use coding, using Haven and Green's medical interview oral rating scale to use the Q, like this is a Q responding model, just to see how the nurses respond to the patient's cues. And so again, for those of you that's linguists, basic unit of observation for this kind of cues observation is each term of the speech for both nurse and the patient. And the term is everything a current speaker says before the next speaker takes over. So this is what we looked at. And within this cue responding model, they're looking at levels, function, and form. So there's basically 3 levels of patient's cues. And how do we actually assess the level? The level is based on the extent to which the feeling will disclose. So for example, level, when patients say something, it may be hinting at something. And level 2 may be explicitly mentioned about the worry. So it's very clear, I have pain. So, so it's very clear. And level 3 will be, I have pain, and the person may be crying. And so you know that's probably very painful. And so each term was then coded with also the function. So the function could be once when the patient expressed the cues, whether that's being explored by the nurse, or whether there's been a knowledge, followed by explore, or not explore, or simply acknowledge, or prematurely give advice, or switching to other topics such as distance, from the cues. And we also look at the form. That could be directive open questions, screening questions, negotiation questions, or summarizing. And so some examples here is for directive open questions. So simply, it's not just yes or no. The nurse will probably continue and say, you're worried in what way? And then that could be also screening questions about what the patient has, what kind of concern they might have that has not yet been discussed. Negotiate question could be you wanted to close, a particular topic area and move on to something else. So you negotiate with the patient. And summarizing, I mean, just like anything. So you summarize things that the patient has talked to you about, and you're probably trying to provide feedback to the patient. But then in the form here, what we found is oftentimes is directive open questions. That means the patient will, the nurse will actually ask more about the concern that the patient might have, and similar to more like exploring in that sense. So, but put the Q responding aside for the time being, the thematic analysis that we found from the triangulation of the field notes and also our interview and also document review, what we found is two particular themes. The first is patients' perception nurses' workload, and they are very heavy, like the environment. And then the theme two is looking at the nurse-patient's partnership and the role expectation. So this theme, patient's perception, nurses' workload, and the environment, it is interesting that patients seem to be familiar, like they're very familiar with the nurse's work pattern, and also realize that this is very heavy. And so that led to the sympathetic feelings for the nurses, and then also resulted to how they prioritize the care or prioritize the call when they meet the nurses. And also I'll go into a little bit more detail about how do they actually do the partnership, and also looking at the nurses' role in psychosocial care and how the psychosocial care related to the physical care. So the first thing, sympathy for the busy nurses. So understanding the nurses' heavy workload and also familiar with the work pattern. These are what the patients told us during the interview. The patient would say, nurses are very busy with the work. So many patients. In the morning, they're very busy around 9 to 10. And then again, 3 to 4 in the afternoon. They need to give out medications and sometimes help to check the patient's body and ask about the conditions. And then there's also patient talked about, that's too much paperwork, but then you wouldn't have any record if you don't have the paperwork. Nurses are really too busy. Every day the shift handover is done by 3:15 in the afternoon, and then nonstop till 9 without any supper. I can see that the nurses in this cancer ward have worked very hard, administering medication, taking temperature, changing diapers, so they can actually tell you what they do. And we at times, like even within nurses, we joke about, like, are we doing paper care or patient care? So this is, I think you from your own study, you probably have found that too, a lot of paperwork. Nurses' work is very heavy and demanding. With 6 people doing 8 people's job, it was hard. So this again showed that the patient seems to be very sympathetic towards busy nurses. And from our own field notes, we also realized that our nurses are the busiest during doctor's round on weekdays, and they rush in and out of the cubicle many times. They run from one patient to another in the ward. Commonly, nurses are providing procedural care for one patient, while they will be speaking loudly to another or responding loudly to another patient in a cubicle. And another few notes that we observe or documented is one cubicle is crammed with 10 or more beds. I think we can all visualize, how busy this can be. It is common to see crowded environment full of 10 beds and stretched in the corridor. The distance between the patients so close that the conversation of nurses are easily overheard. So the environment itself is not very conducive, to any kind of private or personal conversation. Patients' privacy is likely being breached, when neither concern disclosed. And besides, there's a lot of noises, patients cough, cries, moans, and also some kind of noises coming from the equipment, such as the electronic cardiogram, the venous pump, So when we look at the isolation room, on the ward, those areas might be less crowded and maybe less noisy. But then what happened is this location is usually far away from nursing stations, and nurses only approach those patients routine care or when patient actually call for help. So like the nurses won't make a, like won't necessarily walk around there. So if the nurses don't walk around, the patient there will have less contact with nurses. So again, the environment itself is not very, supportive for any conversation that is probably more private. Then, as I said earlier, because of how the patient feels the sympathy towards the nurse's workload, they tend to prioritize their call. So they call them, rated them as urgent and not as urgent. So then when we ask them, what do you mean by most urgent? Then they'll give example like yesterday when I think of high blood pressure, as 190 over 108 in the afternoon. I asked the nurse to take it again at nighttime. I think it is a serious problem that I need to raise it immediately, and I'll do so if I have abdominal pain. And then another patient would say, I vomited something like blood before, and I've told nurse about it, even though she looks very busy. It is very important because nurses need to make a record of it and let the doctors know about this. And then another patient would say, I'll ring the call bell if it's really urgent. Sometimes my colostomy bag is broken and it's something that's urgent because it's dirty. So again, this is an example what the patient would say, that's an urgent call that they need to make. And what is less urgent? So some of the example here is the patient will find opportune time to communicate with nurses and they won't call them or they won't disturb them when they're busy. So one patient would say, I wonder what I can do better. This is actually the same patient talking about the colostomy bag. And so the urgent to them is when something is broken or, like dirty. And something that's less urgent is when how would he does better with his own care of colostomy bag. So he said, despite the fact that he's been learning about it every day, but he still can do it very well. So he will ask the nurse about that when the nurses are free to come in. Or another patient would say, I will wait till the nurses completed their work since they are not to be disturbed. If not, they will give out the wrong medication and I'll wait for a best opportune time to talk to them. And then yet another patient will also said, I haven't mentioned about the financial concern to nurses here. They think I don't need target therapy at the moment, so I don't think I need to ask anymore. So again, they would think that this are definitely less urgent because something that can be wait or until later. So for nurse-patient partnership and the role expectation, for partnership to occur, for the patient to be able to partner with the nurse, the patient will have to have a familiarity with their own conditions, and also they will be able to initiate communication and have the ability to share some of the self-care responsibility. Some of the patient will say, like this are the one that can be the partners with the nurses. This patient said, I always praise nurses today. There's nothing wrong with the blood vessel. If it's swollen and painful, I ring the call bell to find them. So not to worry. Nurses will try the best to help us. Should be considerate of them. They work very hard. Already it's very satisfactory. Nurses has no time to talk with the patient. She has a lot of work to do. And then another patient will say, if I miss any medication, I'll tell the nurse directly and let him or her inform the doctor. And we also see from the field notes how nurses themselves also try to empower the patient. The nurses will explain the possible side effects of the chemotherapy to the patient and instruct them to respond to an adverse reaction or how do they feel or any problem with the intravenous during the chemotherapy and to bring them right away so that the nurses can attend to the problem. This is one of the examples of how small talk can facilitate the building of relationship and hence the partnership. So this is again during administration medication procedure and the conversation between the nurse and the patient about the chemotherapy. The nurse said, post-chemotherapy is a big deal. And the patient said, no, now, must ring the bell for you if I have problems during chemotherapy. Then the nurse said, yes, you're right. And the patient said, yeah, it depends all on you. And the nurse said, we also depend on you, really need your help. And the patient laughed. Now I depend on all on your work and health and the nurse saying, so that was this back and forth kind of conversation. And ultimately the patient said, yes, you've done a lot for me since I'm here. So again, that's very appreciative of what's happening and is working together as a team. So with patients' partnership with nurses, as we said earlier, the rapport has to be developed. One patient actually summed it up nicely. I think I can treat the nurse as a friend. If I have a need, I can communicate with him or her. The nurse gives me confidence. Now, another thing that we find out is, obviously, when we develop rapport, the patient will also felt that they have confidence in the nurse, that the nurses that they can help. Then they will talk to them about things. Now, we also have the flip side of the scenario. We also have nurses that seem to be unfamiliar with the patients. And when unfamiliarity occurs, they might have misunderstanding. One example was there was a patient who was diagnosed with brain metastases, and a nurse who, like this nurse, wasn't very familiar with the patient's condition, just assumed, given the diagnosis, it's difficult to communicate with the patient. But then when we reviewed the document, the patient's actually conscious, alert, calm. The person is quite clear and relevant with speech, and the person is willing to communicate. And from our own observation, we also find that the patient was very cooperative with clear and relevant speech. Granted, her response was a little slow, so you have to kind of be patient and bear with her. But then if you understand that she could communicate, then you'll be able to see her very differently. And then other misunderstanding could also due to lack of information that was provided to the patient. One of the patients shared with us about discharge. And she said, I don't know when I'll be discharged. If I knew I was going to leave today or tomorrow, I wouldn't ask the nurse to change the nail. Since I thought I wouldn't go home so soon, I asked the nurse to change the nail for me. But she said, sometimes kanji, sometimes rice, change again and again. I sensed that I was troublesome to her and she didn't like me. This made me upset. I dare not communicate and talk anymore with her in the future. So again, sometimes some of this thing could be could definitely be rectified if more information can be given to the patient. And another one that's actually, I think it's even more important for nurses to be aware of, that we have shared with the nurses. The misunderstanding came from assumptions. And this is again a scenario about administration medication. So the nurse has just given the medication to a patient and then continue with her nurse patient round. And all of a sudden, she spotted the patient, took out the medication from her own drawer, a medication that she had brought from home. And then, well, it looks like she was looking at them, but she wasn't, the nurse wasn't sure. So the nurse was very concerned and basically yelled across the room and said to the patient, and this is how the patient recalled what's being said. The nurse shouted at me, don't take your own drugs. Do you want to die? I knew she was afraid that I would take the medication from my home. After that, I explained my act to her. Then she said nothing and left. So again, there was obviously some misunderstanding from the assumption, but the intention of the nurses was actually good. She was just worried, and then she worried that she wouldn't be able to stop the patient fast enough because she was away from where the patient was. But then afterwards, even though the patient has explained to the nurse didn't really apologize for the misunderstanding. So again, there was negative nurse's attitude seems to be perceived by the patient and affected the nurse-patient relationship. And so the patient wouldn't be talking to this particular nurse after that. In terms of nurses' role in psychosocial care, as we said earlier, it's very interesting that not many patients actually know that the nurse's role in psychosocial care, apart from the fact that they also mentioned about if they weren't familiar with the nurse, or if they haven't been working with nurses for long, it's also hard to share with them about what they feel, what they need in terms of psychosocially or personal issues. So the patient would say, the patient actually said to us, as an example, one of them, I believe that the clinical psychologists and doctors are trained with counseling skill, having lots of tools and medication to help psychologically. It is difficult also to get familiar with nurses in 1 or 2 days. Like, so some of them may have a shorter stay. They may be coming in and out with different nurses looking after them. And then some of them just simply don't expect the nurses role in psychosocial care. And this particular patient said, nurses can help me. Asking the doctor to make a referral to convalescent sanatorium is the only thing that they can do for me. And one of the wife of a patient also talked about, we now hope the patient can have the electrotherapy as soon as possible for earlier control. We're more scared day by day, hoping for cancer treatment. But I don't know whether nurses can help. So again, that seems to be a gap between what the nurses role or what the nurses can do for the patient, you know, in this aspect, as compared to what the nurses can actually do. So with the other theme, looking at the sub-themes, looking at the reduction in psychosocial concerns through physical care. Now, we all know that under biomedical model and within a very time pressure environment, clinically, nurses put the ultimate focus on physical care. That's actually the highest priority. But then with the appreciation of patient of nurses' physical care, and also when they do not expect nurses to meet their psychosocial needs all the time, or some of them don't even expect that nurses should meet their psychosocial needs. By doing good physical care, that could actually lead to maybe to mitigating the effect of the psychosocial concern or needs. One of the examples here is the patient said, I haven't talked about my worries. First, nurses are too busy. Second, they can't solve the problem. Actually, they can't help because they have their own responsibility. They have already done a lot for us. Sometimes couldn't walk myself or really have a need for linen, water. They were willing to give me a helping hand. So to them, some of the nurses are some of the patients are very frustrated when they can't really do much for themselves. And when the nurses can, lend a hand and make them feel comfortable, this can actually ease their worries too. And if we look at some of the cue responding mechanism, how the psychosocial care could also be realized through good physical attention of care. Things such as, again, during the administration of medication, how this dialogue can actually help to ease the psychosocial concern. So the nurse came in and said to the patient, this is actually the night shift. After taking the analgesic tonight, please let us know if you're unwell or if it's ineffective that you have more pain at night. And so the patient responded, say, don't you mind? And so we actually put this as level 1 because it wasn't very explicit, but the patients actually hinted the fact that wanted to clarify with the nurses whether it will indeed be fine for the patient to raise the issue about the side effect of medication to the nurse even at night. And then the nurse said, no, I don't. By the way, the analgesic is given to you before physiotherapy. Is it useful? So the nurse was actually talking to the patient about what happened during the day when the patient went for physiotherapy. And then so the nurse actually acknowledged. The patient said, do you mind? So she said, no, I don't. And then continue to explore with the effect of the analgesic, especially during the physiotherapy. And so the patient said, yes, but the legs are weak and floating. And so this is actually what we put as a level 2, simply because the patient make it very explicit that it is helpful, but the legs are still weak. And I felt like that was hard to kind of move it. And so then the nurse was saying, yes, because you've been on bed rest for all this, in this few days. So you have to build your strength. And that's why I give you morphine before physiotherapy every time. So if you don't feel well, please let us know and tell us. So we'll give you analgesic anytime, meaning that if the person's in pain. So that would good acknowledgement, and also the nurses will also explain to the patient as to why the morphine is needed, and it will be helpful. And what happened to the legs, and that's why the physiotherapy is very important. And then the patient wrapped it up and say, thanks, that's helpful to know, and I felt less worried. So again, even within a quick dialogue like this, it will help to ease the patient's concern. Another probably a differential responding example, which shows the opposite effect of it. So during the administration of medication as well, and the patient said, I feel better now, and so I don't have any pain. So the nurse actually came in to do to again giving morphine, and so the patient just giving pain and say, I don't have any pain, so indicating that the person doesn't need any morphine. And then the nurse acknowledge it and say, well, the medication effects still remain, and that's why you don't need it now. And so you're now free from the pain, but your pain will return while the drug level is decreasing. So once when the drug level is start to decrease, then your pain will come back. And so it will be more difficult to control your pain with the same dose. So we need to stagger the dose. So the nurse is trying to explain to the patient. So the nurse did acknowledge the fact that the patient didn't want the morphine, but she was trying to explain to the patient why it's important for him to have it. So the patient said, no need, I don't take the morphine. So this is very explicit and clearly, I don't need morphine. So express refusing it. And then the nurse said, if you don't take it, you may have greater pain. So acknowledge that, but they just basically indicate it as a statement. And then the patient said, no, I mean, not have any pain, just responding to that very explicitly. And so the nurse said, well, it's fine then. If you don't take it, let me give you the injection vitamin B12. And then the patient said, okay. And so there was acknowledgement on the nurse part, but we also find this distancing. There was some kind of premature closure. Later on, we find that from the patient that there were side effects of morphine that he didn't like. And so that's why he didn't want to take the medication, not because that he feel less pain. And so again, that will be a potential issue with the patient, with the pain control. So this is certainly something that for us to learn about in terms of the distancing from the distancing. And this is another example of distancing. Again, during administration medication, the patient was actually a little bit scared of injection, and the patient actually talked about it very explicitly. So that's level 2. When the nurse came in with injection, the patient just simply said, I'm always scared of injection. And so nurse acknowledge, don't be scared, and just don't rub the injection site, it will bruise the site. And so again, it hasn't really quite eased the anxiety of the individual, just simply acknowledgement. And also I have some kind of distancing, like I move on to another topic. And from our own field observation, we realized that there was nurses, there was one particular nurse in particular, we see that how she tried to ease the patient's anxiety about the IV injection of medications. And so the patient actually conveyed that to the nurse. So when the nurse first came in, she'll initiate chat with her in a very friendly atmosphere. They probably joke a little bit and they both laugh when talking about the patient's experiences with social activities. And then the patient asked the nurse to give the injection more slowly because of pain. So because some of the medication could be very painful when you injected it. So the nurse then reassured her and the patient expressed satisfaction in the nurse's help in administering medication for the symptoms. So again, it was helpful by recognizing the physical care, how the physical care could help the patient with some of the issue of the anxieties and worries. And so I guess I just wanted to conclude here. So the patient general appreciation, nurses' work demand, and their care actually shape how the patient communicate with the patient, with the nurses, by having more of an urgent call or less urgent call, for patients, for nurses to come and talk to them about their needs. And that's also a possibility of nurse-patient partnership through patients' knowledge and then how familiar they are with their own treatment regime. and how ready they are in terms of carry out the self-care responsibility and also their ability to be able to do that. So one of the things that we point out to nurses is we also need to, obviously attend to the changes of the patient's ability to be a partner. And then the other is looking at the role of the nurses in providing psychosocial care. Simply because the patient weren't aware of this role, and some of them they may aware of this role, but then didn't think that they know the nurses long enough to be able to share that kind of concern and anxieties. So the nurses might wanted to listen and understand the different views of the patient in order to bridge this gap of what the patient expects and what the nurse can actually do. And educate the patient about the role of the nurses and how we can better utilize the procedural time to do small talk and to get to know the patients and to understand them as a person, and before go on to, for them to feel more comfortable to talk to nurses about the personal issues. And then obviously the interrelationship between physical and psychosocial care is very important. I think when we're looking at holistic care, we oftentimes should look at physical and psychosocial together. They are actually an integral part and they are interrelated. But for some reasons, we often separate the two. And so, for a patient to tell us that, this should be together, and even when nurses in a very busy time, if they can look after us, in a good physical way, this will actually help them already. So this gives a broader meaning. I would say broader meaning, but at the same time, we look at the literature, just kind of bring you back to the fact that physical and psychosocial should always be interconnected, shouldn't be separated. And also the patient's appreciation of this impact of physical care will give an alternative way for the nurses to look at, how they can fulfill the psychosocial needs, given the fact that, oftentimes we do put a lot of focus on physical care within the biomedical model. The implications, some of the implications that we found, and as you can see, how stressful the nurses could be, and we recommended that there could be some reflective workshop for nurses to learn about communication through a model of appreciation rather than deficit. So looking at the strength of the patients, looking at how to empower the patient so that they can see communication with health professionals very important, and rather than focusing on what they cannot do. And this could also be related to how we can promote partnership with the patient, and also encourage nurses to possibly looking at mindfulness practice to improve their communication skill. And what we have observed too, oftentimes when nurses are stressful, the tone of voice and also the language that they use, or maybe the choice of words may not be the most ideal, and they probably realize that afterwards. And so mindfulness training, maybe just even the most simplest way to take a deep breath, or maybe give herself 1 second to center herself before she move on to our next patient or going into the next room, will be very helpful. And ultimately, role modeling and leadership is very important to develop a work culture, in communication. And so I think this is something that I wanted to share with all of you. And unfortunately, when we wanted to share this with the nurses, we weren't able to, but we were able to share with the senior management in the hospital. And so hopefully the nurses will also get the message that the patient very appreciative of their care, especially witnessing how busy they were. And so I guess the nurses do need to have a lot of praise, during the difficult time. So I just want to stop here. So maybe open to any questions or comments.